Hi, everybody. Okay, and thank you, Laura, for the very kind introduction. I'm delighted to be here with you today. And I want to emphasize that the most important goal of this presentation is helping all of you get connected to the work that's being done to improve the delivery of behavioral health services integrated within primary care throughout the Panhandle, as well as the opportunities to integrate health within behavioral health care in specialty locations like the Texas Panhandle Center and in behavioral health settings within Texas Tech and wherever, in order to better meet the needs of the entire population in the region. And this is a very ambitious agenda that Laura has brilliantly spearheaded to create the Panhandle Behavioral Health Alliance. And all of you are potentially welcome to get involved, either for the purpose of advancing what you're doing within your own particular part of the world, or even better, to be helping the other team members to spread the ability to develop capacity throughout the region. So when we talk about prevention and early intervention of mental health and substance use disorders inside primary care, what we're talking about is the opportunity to develop an integrated framework within health settings to better address the needs of the people with mental health and or substance use and or cognitive challenges and or trauma and or life challenges that are already there. So let me ask you guys, how many of the folks here are working in or connected to the delivery of primary health care? Okay, and among you, do you find that people in primary health care have behavioral health challenges? Okay. So is that weird to discover that, like 1 in 1,000 patients, or is it pretty common? Okay. So part of what we're talking about is not to be thinking about integrating behavioral health into primary care as some weird special thing, so much as the opportunity for us to be thinking together, everybody within their own capacity, to improve our collective, separate and collective ability to better deliver services that are matched to the needs of the people that we actually see. And this is what I do for a living. I go all over the planet working with my partner, Dr. Klein, and we consult to large systems about helping systems develop services that are matched to the needs of people with all kinds of complexity: mental health and substance, behavioral health and cognitive, health and behavioral health, housing, criminal justice, all of this stuff. So this is a subset of what we do, is to talk about this particular issue. And the message that's important is, how do you connect this to what's in your heart that brings you to the work and the work that you're already doing? And how do you figure out how to improve it so you're doing better and having more fun addressing the complex needs of the people who are already there in front of you? Now, in the starting of this conversation, I want to talk about kind of helping everybody frame the way the system is currently designed and the where we want to be. So I call this the complexity challenge. If our goal in the Panhandle, speaking on behalf of the Panhandle Behavioral Health Alliance, is that we want a regional system of care in which people with needs can get the kind of help that they need wherever and whenever, we want to design our ability to create that system around the people who need us the most. And so I like to start with what I call the complexity challenge, because systems tend to be organized into what we call silos, Like there's a health silo over there and a behavioral health specialty silo over there, as an example. And, and then we feel distressed around the people who don't fit. And this is the complexity challenge. People with overlapping needs. So let's think about any person of any age with any combination of any health problem or need and any mental health problem, including an experience of trauma, which I think most of you know contributes to a variety of chronic disease conditions and to poor outcomes, and or any substance use or addictive issue, including gambling or even nicotine dependence. Yay, tobacco-free Amarillo. I asked, woohoo! Okay? Whether or not that person has already been diagnosed. So one of these things we know about this particular group of people is that they're everywhere in the delivery system. They're in behavioral health settings, they're in health settings, they're in jails, they're in housing settings, they're all over the place. People with overlapping health and behavioral health needs. And they're in all of your settings, as you said. And there's not just one kind. There's lots of different examples. And, you know, I put out some examples that you might be familiar with. I mean, there's, you know, somebody who is, you know, a person who's an older adult who is suffering with chronic pain and losses, maybe cancer, who is suffering from depression, doesn't want to talk about it, doesn't want to ask for help, has suicidal ideation. And where are we going to intervene to help that person, you know, improve and prevent an eventual suicide? On the other end, we have youth. We have kids with potential attentional deficit disorders who are having problems in school. Maybe nobody's ever even diagnosed them or screened them for treatment of their ADHD. And they're starting to use marijuana because somebody convinced them that marijuana helps their brain settle down. And they're not about to walk into a behavioral health setting, but they may show up in their primary care setting for some kind of health check or a sports physical or whatever brings them in to be seen. And then there's the universe of people who are suffering from common chronic medical conditions. And there are people who have, let's say, diabetes or, you know, and, you know, as doctors, we give them a whole list of instructions of all the beautiful things we want them to do. You know, follow this diet and take this medicine and do this exercise and lose this weight. And the person doesn't seem to be able to do all those things. And we're feeling frustrated, and she's feeling frustrated, and she's losing hope. And we're not aware that she's suffering from a history of trauma. She's currently in a relationship with an abusive partner who's alcoholic. She's got a kid with developmental disability who's got poorly controlled seizures. And she has a history of trauma in her early life. And, you know, instead of her experiencing the health world as, hey, a nurturant place, it's just making her feel bad, making her feel like a failure. And we're getting frustrated, she's getting frustrated, and she's not making progress the way we want. And these are just 3 examples of the varying kinds of people with complexity that walk into primary care every day. Some with more severe problems, some with less. And what we know about complexity is not only that these folks are everywhere, but whatever issues you start with, you're immediately likely to be finding others. So people with overlapping behavioral health, and I'm using that term for mental health, substance, cognitive, all mushed together, and health, medical challenges, also have housing issues or legal issues or parenting issues or disability issues or financial issues and so on. Okay, so there's all kinds of stuff going on. And we also know that the more complex you are, the worse you're likely to be doing. So these are folks within the total system who are likely to be having the poorest outcomes in multiple domains. And those poor outcomes include that they're more likely to not be doing well with their health conditions, not be taking good care of themselves, having more emergency room visits, more recidivism, and higher cost. And depending on where you come into this, whether at a personal level, I want to see my people do better, or you're managing a big ACO, which means I want to gain money on my financial upside, this is important. Okay? So if these are folks who are having poor outcomes and high costs, then naturally we would think everything about our system would be designed to prioritize the people with complexity who are most in need, doing worst, with highest cost. But it doesn't take you 2 seconds to realize that historically, and in so many ways currently, the opposite is true. That these folks have been, the system has been organized so that we all tend to experience these folks as misfits pretty much everywhere they show up. At the system level, we're always feeling like people with overlapping health and behavioral health have dared to have more than one problem at a time in systems which have been funded and regulated as if everybody had one problem only or only one problem at a time. And the programs, the clinic structures that we've organized seem to feel like a mismatch for the people with more complex needs. We tend to organize our health delivery as if our modal people were all simple. Okay, and then when we have people who have all these challenges, it feels like we have to contort ourselves to fit them, or they have to contort themselves to fit us, and that doesn't seem to work. In addition, those of us who are in the primary health world, and this is true in the behavioral health world as well, often experience a misfit between what these people need and what we know and how we were trained. Okay, so that we're feeling like these are folks who mismatch our ability to know how to be helpful. And further, when there's a mismatch, we also wind up winding up with difficult feelings because these people don't fit neatly into the way our practice is organized and the way our work is delivered. They stir up feelings in us, ranging from feelings of helplessness, hopelessness, and despair, all the way over to frustration, irritation, and rage because they don't do what we want. And they become the antisocial, manipulative, borderline, med-seeking, non-compliant sociopaths. And we're often introducing them to the rest of our team before we've ever met them. Guess who's back? And guess what? You're going to deal with them this time. So these folks who are having the poorest outcomes and the highest costs are not only not prioritized, they're folks we're often inadvertently holding at arm's length. So one of the starting places for beginning to shift is to think, how do we organize ourselves in our own world so the people with the greatest complexity are purposefully welcomed for help inside what we do, whenever and however they show up, because they're the folks who need us the most. The second thing that we've learned is the importance of what are we welcoming people into? Because very often folks start with, well, I can't welcome you into anything until I figure out where to send you, like welcome and out. But actually what's important is that we begin with some of the things we already know how to do in the business of delivering care. We want to inspire people with complex challenges that progress can be made, that they made a good decision by virtue of coming to us because we care about them and that we know they have lots of issues and we're going to help them make progress so they have better lives. And that's called inspiring hope. And hope is important for all of us. None of us ever wants to be, hope is the energy that keeps us going when we're dealing with amazing challenges in our lives and it feels overwhelming and we don't know what to do. Hope is the energy that allows us to do the difficult work of managing complex medical conditions and mental health conditions in the face of, life challenges. And none of us wants to be the place where when people with complexity show up at our door, we wind up taking their hope away. And one of the ways that my partner and I got started is she hired me when she was the medical director of behavioral health in the state of New Mexico. And one of the things that she was immediately assigned to do when she took the job was to sit on the state mortality review committee, where they looked at everybody who died in the public system. And what they quickly discovered is that people with greater amounts of complexity died earlier and at higher rates than people with single problems and who died higher rates than people with no problem. And they died of lots of things, but mostly they died of common medical conditions, not because they had no connection to care, but because they weren't doing the things that would have kept them alive long. And they noticed that a lot of these folks died within 4 to 6 weeks of having knocked on a behavioral health door. And then they die of a medical condition. And they couldn't figure this out from the chart, so they called the families. And the families told them this amazing thing. When our person knocked on your door with complex needs, they came away with less hope than they started. Because people met them with a like, oh my goodness, you're complicated. I'm not sure what to do. And so off they would go, and then they would make bad decisions because they lost hope. And for many of them, those bad decisions, they were so close to the edge that they could die within 4 to 6 weeks. And of course, many other people, most people don't die, but they get worse. So we want to be in the hope-inspiring business, especially for the people who need us the most. So that's another driver for thinking about this. What's another driver? Well, one of the things that's important is getting back to what we said before. We think about this as a system problem because people with co-occurring health and behavioral health needs are not only doing poorly, there are lots of them. And the prevalence can be counted in all different kinds of ways. I'm doing a little work with Regions Health Network with Joseph, and so they did a week or two of screening everybody. And they wound up with 30 to 40% positive, depending on which tool they were using. That's a lot of people. And it's not like we don't know this. We do. You all do. You see it every day. What's striking is the degree to which we've organized ourselves as if this were rare. So we have a system of care with limited resources, and we have all these people with complex needs, and we keep putting them into places designed as if everybody only had one problem, guaranteeing poor outcomes and higher costs. All the while we're wishing for new magic pots of money, which we're not going to get, to deal with the weirdos. And they're not the weirdos. They're the normal people that we see every day. So this becomes a major driver for change. If our job is to design our services to be about the people who need us, then we all have to be in the co-occurring business because we're all serving co-occurring clients or patients depending on where we are. So every primary health setting is in the behavioral health business, whether you know it or not, because those are your people. And you all want your people to do better. So this immediately gets us into a different domain. Well, how do we be in the behavioral health business? And the first thing that people say is, well, there aren't a lot of psychiatrists out here in the Panhandle. Duh, I didn't know that. Gee, I thought you had hundreds of them stacked up over by the, on the freeway somewhere. No, of course not. That's why this is even more important. Because if we have all of these people with behavioral health needs, we know that we're not going to be successful if our model is that everybody with 2 problems has to attach to 2 specialists and 2 funding streams, so we go broker than we already are and drain our resources even further. All of us have to be in the business of improving our ability to provide services that are designed to welcome, inspire, and provide integrated help to the people and families with multiple issues, behavioral health and health, that are already in our doors, inside our practice setting. Okay. So this is what the Panhandle Behavioral Health Alliance Integrated Services Delivery Radical Underground team is up to here. And they're asking you to join in and figure out how to do this. So how does this work? Okay, what do you do? Well, the model of transforming systems is that transformation doesn't take place in Austin, although, a lot of times people in Texas somehow think that's where it all happens. The legislature is going to pass a new law and then the world's going to change as a result. It happens locally. Everybody can be part of helping to transform the system. You can't transform the whole thing by yourself. You can only look at the part you have some ability to do something about. But if everybody gets connected and says, hey, I can take a few steps forward, I can take a few steps forward, then you have a transformational process going on. And that's what these characters are up to here. And they brought me here to tell you about it because they're scared that somebody will shoot them if they got up and said it. So in the framework that we use in our system change efforts, what we say is that every program is a co-occurring or an integrated program. Every program becomes welcoming, hopeful, recovery-oriented, trauma-informed, and co-occurring or complexity-capable. And for primary care clinics, that means every primary care entity has to be in the behavioral health business. Integrate behavioral health into what you do inside your job, inside your resources, not for some other people, but for the people who are already coming in. And the more organized you make that, the better you'll do. Okay? And not only every program, every person. The clinics that do the best, think of this as a team sport. It's not just about somebody writing prescriptions for medication. It's we're all a team to help the people who come in and figure out what we can do for them. And we're all a team engaging specialists when we need them to help us first as consultants, as partners. Okay? And we emphasize the ability of more people to get what they need inside our door and fewer people, only those with the most severe needs, who gets referred out to specialty services which are limited. It's a little bit like, treating other common types of medical conditions. We don't refer everybody with diabetes to an endocrinologist. We don't refer everybody with hypertension to a cardiologist. We have our ways of working with the things that we routinely encounter, and we build that into our entire team. And the more that we develop our practice around that, the more successful we are. Now, this doesn't happen overnight. I call this a 12-step program of recovery for systems or organizations because it's a language about how organizations can improve slowly with big rounds of applause for each step, just like somebody goes to an AA meeting and they get a big round of applause for one day of success. It's the language of quality improvement in healthcare that helps you to improve your ability to match the needs of your population. So that's what it means. You start thinking, and this is the thinking, in my practice, in our practice, in our clinic, in our organization, whatever. Okay, if back when we were organized at the beginning of time, if we knew then what we know now about who we were going to be serving in terms of their co-occurring mental health and substance issues, and if we knew then what is known now, and there's actually a lot that's known that's pretty simple to do right. If we knew then what is known now about how to actually help these folks within what we do, how would we have organized our work, all of our policies, procedures, processes, practices that govern our business, on the assumption the next person we see is likely to be complicated, and it's easier to organize our practice around the half or so people who are complicated, and then the simple people are easy, rather than organizing our practice around the simple people and then constantly tearing our hair out around the complicated people. Okay? So that's what this is about. And there are actually tools and processes for moving this along. We were talking in the Primary Health, Behavioral Health, PBHA committee this morning about ways that we can measure simple levels of progress for every clinic, and also tools that clinics can use internally to say, how do we look at ourselves and find things to improve? And you have places here in the area that are already moving down the path that can be your peer leaders and mentors and are eager for you to ask them for help. Okay? And you contact Shri and say, hey, we're doing something, whatever it is, and we need help. And Shri will say, we can help. And then she'll find somebody to talk to. Pretty cool. So, okay. Now, is this your vision? You don't have to answer. But most people say, well, it sounds nice, Minkoff, but how the heck do you do this? I mean, we're all busy, we have limited resources, we have lots of challenges, and so forth and so on. It's easy to come up with the things that get in the way. So it's important also to realize that we start with what we can do, and we organize the things around what we know works, and then we make steady progress. So we know two things. There's been a pile of research on how to help the kind of folks we're talking about. And it has all kinds of, there's fancy names and different models and this, that, and the other. But, my work has been get past the jargon and look inside the research and say, what is it that they actually do that's helpful? And let's stop making it sound like academic gobbledygook, and let's get it right down to simple, helpful stuff and make it so that any good set of people trying to be helpful can figure out how to do the things that work and don't do the things that don't work. And over the years, over 20 years of doing this with all kinds of complexity, we've identified 6 research-based principles of helpfulness, each of which can be translated into interventions that you can actually start improving the doing of inside your actual clinic. Okay? And to the extent that you don't have to, if you can hire a behavioral health specialist, that's great, but if you can't, you can find somebody who wants to be helpful to you. And if you can't find one, you call Joseph or Tim, and they'll help you find someone who will want to be helpful to you, as just part of your team, so that you can ask somebody questions as you're moving along. So there are 6 simple principles. Now, the other thing is how you do this organizationally. And one of the big movements in medicine generally, in patient-centered medical home, is having all of us be in the quality improvement population health business, using the tools of quality improvement to steadily improve our ability to deliver services for the people who need us. Almost all of you are familiar with doing this around particular medical issues. And some of you have incentive payments designed around specific processes. These same quality improvement strategies can be used to the same framework, plan, do, check, act cycles, data-driven improvements, small steps of change, working as a team inside your clinic, so it's not just up to the doctor or up to the nurse, it's everybody can play a role, can help move this along in small steps and big rounds of applause inside your own quality improvement framework. Okay, so this is the big umbrella for how you get started. So where do you start? 6 things to think about. First, remember in your world that complexity is an expectation. So the most important people you're serving are the ones who are going to have the hardest time. And only a small subset of those are going to be easily referred out to somebody else. There they are, they're in your practice, and you love them because you love everybody in your practice. But the starting place is to incorporate this on purpose in a welcoming manner into everything we do. So we want to, because these people need us the most, we want them to feel that when they show up, they're in the right place. And welcoming is not just about being nice, because everybody's nice most of the time. Welcoming is built on a technology that we all know called customer service. And if you've ever had customer service training, you know that part of it is teaching absolutely everybody how to respond properly, not to the easy customers, but to those who are the most challenging. So you start with things like basic welcoming. Hi there. You're one of those folks who has all of these complex needs. You have this chronic health condition. We think you're using substances. You probably have some mental health issues. You have a terrible time keeping your appointments. You don't follow instructions very well. Thank you for coming. Okay? You're in the right place. We're really glad you're here. We know our job is not to perfect you the minute we meet you. Our job is to get to know you, inspire you with hope, and help you figure out the best way to stay connected to us so that we can work with you on all your issues in tiny steps so you can make progress toward having a more helpful and healthy and meaningful life. Okay, we're your primary care. That's what we do. We're in the help and wellness business for people with complex needs. And that's not a very complicated speech, but the reason you all laughed is because you know if you don't pay attention to that, that's exactly the opposite of what people experience. You know, it's not like, oh, all my Sundays are like super easy, but if you frame it differently, it helps. Okay, and then there's, the welcoming is not only what we say to the person, it's how we talk about people when they're not there. So we have to stop trash talking people when they're not listening. It doesn't help us help them or help them be with us. We have to stop thinking about, if you show up in a state of disarray, we're going to kick you to the curb. Okay? I mean, welcoming is important because these are the folks who need us the most. And then part of welcoming is the bottom. Okay? Which is welcoming the opportunity to see all of the issues that people have. And this is a very interesting thing in the primary health integration domain. In this country, we've made a lot of effort, and I know some of you have worked on this, to screen for depression. So, we have this tool, the PHQ 2 or 9, and people use it, and it's like, yay, we have a tool, we can screen, and we can maybe do something about it. Yes. And then there's another thing called SBIRT, Screening, Brief Intervention, Referral to Treatment for Substance Use Disorders, and there's a set of things for that as well. And those are all good. We have this knowledge. What does the knowledge tell us? If we do screening as part of our routine process, we have more opportunities to intervene and track progress than if we don't. And there are things that are powerfully successful in primary care. Not for everybody, but for many people. When we catch people early and we intervene in a way that's integrated into their health. Even simple things like a brief intervention by a physician advising people to reduce their substance use when they're in early stages is a robust evidence-based intervention. Okay? Beginning antidepressants for people in the early stages of depression before it takes a more complicated and chronic course. Those are good things. They're all tools that we have. Okay, and the more people we recognize, the better it is. Not only the more people, the more things we recognize. So if you're thinking about this from a population, I don't want to just, okay, I'm going to identify depression and alcohol use in my practice. But I'm not going to pay attention to other drugs. I'm not going to screen for tobacco use or anxiety disorders or psychosis or trauma or ADHD. Okay? Or I'm only going to use one screening lab because getting many screening labs gives me a headache. There's so many things I could be screening for. I mean, what we're talking about is welcome the opportunity to find out as much as you can about who's in your practice. That's what they're doing at RHN. And it's not like immediately they can fix everybody, but knowing what you're dealing with helps you to figure out how to intervene, and it helps you to track the data. How many people are we identifying? How many of them are being successfully intervened with? Let's steadily improve that basic quality improvement. Okay. Now, there are many in this slide, and I think everybody gets these slides, right? So, no, we can't have the slides. It's unwelcoming. What? You can have the slides. You have to do something. Email Tim or Shri, and somebody will get you the slides. Because this is a complicated slide, and it's hard to absorb, and there's a link on the slide. So one of the things that people often ask is, what's the perfect screening tool I should use in my primary care practice? Because everybody's thinking somewhere in the world there's a perfect tool and it's just being hidden where you can't find it. So the answer is, there is no perfect tool. I'm sorry. And the way you learn that is you Google on this thing that says integration.samhsa.gov clinical practice screening tools, and they'll show you like 50 tools. And you'll say, thank you, that's not super helpful. I don't need 50 tools. I need some simple things. So here's some simple things. Most of you are familiar with using some version of the PHQ for depression. Most of the research says that you can start with the 2-question PHQ-2 and then use the 9 as a backup. Okay, and that's helpful, and you can use the 9 as a way of tracking depression, the same way that you can track hemoglobin A1Cs for diabetes and, create a little bit of a registry for tracking. You can use the GAD-7 as a screener for anxiety. However, what I recommend and what I've used is make it easy to screen for multiple issues at once, okay? Because it doesn't have to be rocket science. So there's something called the Mental Health Screening Form 3 that was developed and researched to be used in addiction settings to screen for multiple different kind of mental health issues. It has about 16 questions. It's designed so that addiction counselors could do it. So it's certainly within the capacity of any medical office to do. It's pretty straightforward, and it tells you, you know, like, oh, this gives me a clue that maybe there's this issue. People can fill it out by themselves and so forth. And if you want to move from I'm only going to screen for depression to I'm really curious about how many people have any kind of possible issue in my practice, this will help you to get there relatively. There are some other things that, you know, the patient stress questionnaire, which you can also Google, has depression, anxiety, alcohol, and trauma. So that covers a lot of ground. It's still, you know, it's kind of how far to go. But any movement you make toward, I want to see all the mental health issues, I'm going to find easy ways to do it and track it in my practice, round of applause. Screening and identification of substance use. Of those, there are a couple of things that I specifically recommend. Many of you are familiar with the audit and the cage aid. They're okay. They're not my favorites. And Joseph can even tell you from what we learned this morning about why the cage aid. So I'll tell you the story. Is this all right? Yeah. So we were talking this morning, and Joseph said we were using the cage aid because it seemed simple. Cut down annoy, guilty, eye-opener, and it's drugs and not just alcohol. And the nurses came and said they were trialing it in their clinic. And the nurses said, the patients hate the cage aid. And they're like, why? It's real simple. And the nurses said, well, because it feels like they're being attacked. They say, do you feel guilty about your drug use? And they're like, ooh, you know, it's like, and so, you know, it's like things you don't think about. But you're not trying to attack people. You're trying to make it feel easy for them. One of my favorite tools, you can get this for free, is the NIDA Modified Assist. NIDA is the National Institute of Drug Abuse. And what they did is they took this and set it up for use in primary care. And it has a nice gathering of information about all kinds of potentially abused substances in a very friendly format. And it comes along with information sheets. So if people have positive screens, you can give them information sheets about. It includes even over-the-counter abuse and caffeine and nicotine, and, you know, it just goes through a whole range of things. It's not something, you know, you would take the time to do yourself, but it's something that if people fill out, gives a lot of information. The Brief Addiction Monitor is a good tracking tool. If you're looking for something where you're tracking progress for people with substance use issues in your practice, the BAM is that. The VA uses it in primary care as well as in specialty care as a simple tracker. And so, you know, again, that's something, these are things you can get online. And the opioid risk tool is not for identifying, it's a particular tool. It's recommended for people with whom you are initiating opioid pain medicine for more than a few days. So you use the risk tool to determine whether they're low, medium, or high risk for potential abuse or development of addiction. And then, you know, depending on where they score, that gives you a heads up about how to manage their meds and whether or not to involve a consult. So those are, and that's a simple tool to use. And the Regions folks are starting that one, about to start it, thinking about starting it. There you go. Okay. So that's all just principle one. Even doing this much is a big round of applause. Starting to screen, identify, and then what do we do next? So the next thing is, your job is not to panic because you can't fix everything at once. And anybody who's been in the healthcare business for any length of time, you realize this is one of our most important learnings. We go in like we're going to cure people, just like I saw on TV. And every cure is going to happen within the hour that they're on TV. And then you realize that almost everybody you're dealing with has these chronic conditions, and you do these things and they're not fixed. And many people have multiple chronic conditions. So relax. The best thing to do is to engage people in a relationship, help them feel hopeful, find small steps of progress, build on what they're doing right, feel comfortable with the idea that you're helping people make slow steps of progress over time, rather than you have to have the immediate perfect solution or that you have to know all the answers. Calm down, make it easy for the person to feel connected with you, just as you would for maybe a complicated medical condition in which you're not an expert, but you're trying to help the person negotiate what they're going to do. Okay? So, examples of, I'll talk about some of the ways this plays out, but so in the strength-based world of this, one of the things to remember is that people with behavioral health needs and health needs together generally have multiple chronic relapsing conditions. And approaching people from a strength-based way is an evidence-based practice for helping people like that make progress. And in the land of strength-based, we sort of reframe our language by focusing on not the fact that people are doing poorly because they have very challenging things going on, but the amazing thing is that they're able to do some of the things right some of the time and all of the things right some of the time. And we build on the stuff they do right. So we move from thinking of people as chronic relapsers to moving to thinking about people as being recurrently successful. And we focus on learning in our practice, what did they do right during the period of time they did well? And then how do we help them do that more and better by providing more supports and guidance, rather than feeling every time they slip backwards and their diseases come back that we've totally failed and they've totally failed and we have to start over. Okay? Next. All people with complex issues are not the same. Different programs have different jobs. Okay, so in the world of people with mental health and substance and health needs, there are people with all different diagnoses, levels of severity, levels of complexity, and so forth. And that means that our approach within primary care has to be from a population health framework. It's not one size fits all. It's not the same thing for everybody. And across the region, we have to think from that big population framework. So inside what we do in primary care, we want to help as many people as we can with the common challenges that most of our clients have. And we want to recognize them early and intervene sooner. And we'll do well with lots and lots of people. And as we do this, we're going to get better. You say, oh, well, I never prescribed, let's say, I've never prescribed antidepressants before. Never, even once. Really? Never once. Okay, well, you realize that if the first time you prescribe antidepressants for somebody with depression, you will have infinite improvement. You've gone from 0 to 1. Okay, yay! And the second time, you'll have doubled your production. Okay, fabulous. Okay, and then, the same thing for prescribing naltrexone for somebody with an alcohol use disorder that may reduce their craving or their ability to improve their ability to control their drinking. So, you start and you get better. And then you have people lined up with you that are your helpful partners that if you have questions, you call them and ask them. Just like most primary care people have a cardiologist they call, a neurologist they call. You don't send everybody just for a referral. You call people up and you have a question. And ideally, you build your team so that people answer questions. And then you have people who can maybe see a case once for you. And then the smallest number of people are the ones with the most severe needs who need to be referred to ongoing specialty care. That's a basic population health model that everyone needs to kind of figure out how to start moving in that direction. But not every program does the same thing. Everybody has a different job. Think about the way you start knowing your job is looking at your current cohort of people. Next. Think of all the issues as primary. So the way we do this is you sit, just like we normally do. We have people with multiple health conditions. And we think, okay, what's the best thing for their asthma? What's the best thing for their hypertension? What's the best next step for their diet? What's the next best step for exercise? What's the next best step for their depression? What's the next best thing for dealing with their stressful life situation in terms of health decisions? And break everything down into the next small baby step that they're going to focus on between now and the next visit. And if the whole team can work that way so that they can focus on small steps of progress, okay, then that's integrated care. Integrated care means we address all of the issues in one setting. We may receive outside input and consultation, but we're all working steadily to improve the ability of us to treat more of the people already in our doors for multiple issues. Next, how do we identify where people are? Well, sometimes, we have people with multiple issues and they actually want help for all of those issues. Usually, however, we have people with multiple issues and they don't want help for all of those issues. And there's a language that we use to talk about that, and it's called stages of change. And most of you are familiar with the concept of stages of change for substance use. Pre-contemplation, contemplation, whatever, there's more stages in the slides. And the concept of using strategies called motivational interviewing, which is a lot more intimidating than it sounds, to help people move from earlier stages through the small steps of change. What most people don't realize is that for most people, we all have many issues. Some of them we really care about and we're working hard on. Others, we're in different stages. So if somebody ever says, what stage of change is your patient in? The correct answer is always for which issue. Because they may be real excited about getting help for, asthma, for example. But, if you're talking weight loss for type 2 diabetes, they're not interested in that. Or they're marginally interested in that. You're saying, hey, I think you should cut down your alcohol use. Boop. Okay, but I do want help for pick a mental health problem. So when we match to where people are, then our next steps have to be stage matched as well. And this is a simple way of thinking that's hard to implement because we're normally organized as if everybody is in the action stage for everything. But in the models of care, like SBIRT, for example, things like motivational intervention for people in early stages are built into the work. When you figure out, we can do that for anybody who's in an early stage for anything, and pay attention to it, and my team in my practice can help with this, makes it a lot simpler. And you realize that people are naturally going to be moving from where they start to perfection, but in many, many, many small steps of change along the way. And the final piece is what we've learned is the importance of language like patient activation and helping people to be effective in self-management of their own conditions. So we've moved from simply being, and this is by we, I mean all of us in the help delivery business. We've moved from simply being prescribers, like here's what you do, just do it. Okay, repeat after me. Did you hear what I said? Take all my medicine, do this, do that, come to my next appointment. To realize that people actually need to learn the skills they need to succeed. And learning healthy behavior, especially for people with complicated challenges that interfere with their learning, requires skill-based practice and small steps. Okay, so what we've learned to do is to break things down into small steps. I mean, some of this we've been doing already for years, like how do you teach people to self-administer insulin, for example. But now we're learning that this has to apply to other forms of their self-management behavior. It has to be embedded in their real-world challenge of what their life is like at home, and do they have anxiety or depression that may interfere with their learning? Okay, and so teaching people skills in small steps, having them practice skills in the office with part of the team, checking in to see that they're practicing, even with phone calls, rounds of applause for small steps of success. All of this can help people with more complicated challenges feel more successful as they're working with you over time. So the goal is there are multiple layers of activities that can be built in to any practice to improve your ability to do these things. You recognize that people with complexity are an expectation. There's lots of them. We want our whole practice to welcome, inspire, engage the people with the greatest need. We want to be routinely recognizing that we're going to be addressing multiple issues internally. We're going to get better and better at it over time. We're going to break things down into small steps with the people we work with. We're going to know how to ask for help. We're going to find helpers in the community that help us to be more successful with more of our people and refer fewer of our people. And this, the Panhandle Behavioral Health Alliance team is going to be creating this as a team effort across multiple clinics in the region, so that everybody will be able to say, so here's where we are on the journey. Get a round of applause for wherever you are. Here's how we're making progress. A round of applause for however you make progress. Here's our learning community team. We're going to have learners together. We're going to have helpers together. And everybody can make small steps of progress so more people get what they need inside the resources that we have. Thank you very much.